So welcome. In today's session, we'll be continuing with the series of vasculitis, and we'll be discussing about Takayasu arteritis, which is also known as passless disease or the aortic arch syndrome. Do an introduction. Introduction, morphology, look at the morphology, and then some clinical features. You already know my name. Now, when we were discussing last time, when we discussed about vasculitis, one of the methods we used to classify them is using the size of the blood vessel involved. We said there is large vessel vasculitis, small vessel vasculitis, and a medium-sized vessel vasculitis. Now, under large vessel, last time we looked at temporal arteritis, which is also known as giant cell arteritis. Then today we'll be looking at the second type of large vessel vasculitis, which is Takayasu arteritis. Okay, so this is to be a focus. And also remember, when we are discussing about vasculitis, we said that we can classify them according to the type of inflammation they display. Now, we said that both temporal and Takayasu arteritis, they show granulomatous inflammation, okay, together with the Wagner granulomatosis and Church-Strauss, okay. And then we said with the necrotizing inflammation, Church-Strauss and Wagner. So remember, those two display both types. We also had microscopic polyangiitis and polyarteritis. So those are the ones which display necrotizing inflammation. Now let's look at Takayasu arteritis. Now, as I have said, it is a granulomatous vasculitis of the medium and large size arteries. It is characterized by ocular disturbances with marked weakening of the pulses in the upper extremity. So due to this marked weakening of the pulses in the upper extremities, it is also known as the passless disease. Now, it will manifest with a transmural scarring. So all the three vessel layers, vessel wall layers, tunica, intima, media, and adventitia, will exhibit the scarring with a thickening of, and the transmural scarring and thickening, especially of the aorta, okay, particularly the aortic arch and the great vessels. That is why it is also known as the aortic arch syndrome, okay, and severe luminal narrowing of the major branch vessels. So remember the great vessels which originate the aortic branches include the brachiocephalic trunk, the left common carotid artery, and the left subclavian artery. And the subclavian artery is the most commonly involved, okay? And because it is commonly involved, and remember the subclavian artery is going to the upper extremities, the beginning of the pulses in the upper extremities, hence the other name, passless disease. Now, aortic lesions, the aortic lesions seen in Takayasu arteritis, they share the clinical and histologic features of those seen in giant cell aortitis. Remember, giant cell aortitis is a form of temporal, if I can say, it is a form of temporal arteritis affecting the aorta. Now, since giant cell aortitis share the same clinical and histologic features with Takayasu arteritis, how will you distinguish the two? Now, we use the age of the patient. Now, if we have this, if we suspect it is giant cell aortitis, the patient must be above 50 years, okay? Now, if the patient has this vasculitis of the aorta and he or she is below 50, most likely that is Takayasu arteritis, okay? Now, although historically, Takayasu arteritis has been associated with the Japanese ethnicity, especially the women and certain HLA haplotypes. Nowadays, Takayasu arteritis has a global distribution, okay? And the etiology is likely autoimmune, okay? Though it is not, it is still under investigation. Now, you can see here very clearly, this is the arch of the aorta, okay? Ascending aorta, the arch itself, and then now the descending thoracic aorta. Now here you can see, this is the left common carotid because this is the brachiocephalic trunk. And you can see it is now giving the right subclavian artery and the right common carotid, okay, over there. Then you can see the left, this is the left common carotid, can see some severe luminal narrowing over there. Then you can see in the left subclavian artery here, can see how narrow it is here and over here. Okay, that is Takayasu arteritis. Okay, now how morphology? I told you the affects mainly the aortic arch and the arch vessels. Now, 1/3, that is 30% or 33%, usually involve the remainder of the aorta and its branches. Now, aortic root involvement will cause aortic dilation and aortic valve insufficiency. Okay, and in 50% of the patients, pulmonary arteries are involved. Okay, also renal and coronary arteries can be affected. So I want you to imagine the severity, some clinical symptoms in which the patient will present with if there is renal arteries involved. Now, the takeoffs of the great vessels can be markedly narrowed, okay, and even obliterated, explaining that is why we have upper extremity weakness and faint carotid pulse. So the upper extremities, in most cases, we have a weak pulse, but the lower extremities, the pulses and the blood pressure will be normal. So this is opposite of what we saw in aortic coarctation, where in aortic coarctation, the pulses in the lower extremities were absent, or there was low blood pressure, whereas in those in the upper extremities, it was very high. Now, the histologic picture usually encompasses a spectrum. This spectrum will range from adventitious mononuclear infiltration and perivascular cuffing of the vasa vasorum to intense transmural mononuclear inflammation to granulomatous inflammation, and in the granulomatous inflammation, you'll find the giant cells and the patchy medial necrosis. Okay, this inflammation is associated with irregular thickening of the vessel wall, intimal hyperplasia, hence the luminal obstruction, or the stenosis, and the adventitious fibrosis. So let me show you what this is. This is the arch of the aorta. You can see here there is a markedly narrowing here. Okay, narrowing. This is a branch from the arch vessels. Okay, then you can see these biopsies from these vessels affected here. You can see this was initially the lumen of the artery was up to there, but you can see now it is there. So you can see there is intimal hyperplasia. Okay, so this this intimal hyperplasia even can lead to luminal obstruction, and this can have catastrophic events. It can lead to even distal ischemia and infarction. This is the histologic picture, and here you can see these mononuclear infiltrates. Okay, then here you can see a giant cell. So when you see a giant cell, that is granulomatous inflammation, because it shows you that this is a chronic form of inflammation. Okay. Now, our clinical features. Now, we have, when we discuss clinical features, it is divided into two phases: an inflammatory phase and a pulseless phase. Okay, so inflammatory phase precedes the pulseless phase. Now, during the inflammatory phase, the signs and symptoms will be non-specific, and they include fever, fatigue, and weight loss. Okay, then when it progresses to the pulseless phase, there will be reduced upper extremity blood pressure and pulse strength, and also neurologic deficits. Also, ocular disturbances may occur, which can include visual field defects, retinal hemorrhages, and total blindness. Now, distal aorta disease can manifest as leg claudication, pulmonary artery involvement will present with pulmonary hypertension, and you know pulmonary hypertension is very dangerous because it can lead to the heart failure. Now, narrowing of the coronary ostia, that is the takeoff of the coronary artery, will lead to myocardial infarction. That is also detrimental. Involvement of the renal arteries will cause systemic hypertension, and in up to 50% of the patients. Why? The systemic hypertension, remember the renin, angiotensin, aldosterone system will be activated when you have involvement of the renal arteries. I think that was that very easy, and we have come to the end of that session. And thank you for your attention, and please follow for more medical knowledge. Thank you very much.